All right, we're back with LLSA 2021. One of the articles we talk about is the opiate crisis, but this is another one of those big social crises that we are at the front lines in emergency medicine: intimate partner violence. This is an article by Miller et al. And Salim, I don't know about you, but in my shop, especially with the recent pandemic of COVID, this is something that has become even harder to find sometimes, and so a really important topic.
I think this is something that we've all seen and missed, which is a scary fact. And I think this paper does a nice job reviewing kind of why this is so important, and gives a lot of very good resources as we go through it. But yeah, I think even as a doc, I've probably missed this and just need to be more cognizant of it. And that was one good reminder from this paper for me. So the CDC defines intimate partner violence as either physical violence, sexual violence, stalking, or psychological aggression by a current or former intimate partner. So that's the definition of it. Now, how often this happens is going to be dependent on where you work. Like, for example, if you work in the inner city versus an integrated health system or out in the suburbs, you're going to see a different prevalence of this, but it still occurs in all locations. Now, they give some pretty astounding numbers in this paper. They say about approximately 1/3 of all women and men in the US have experienced intimate partner violence. This article specifically focuses on females, but they do throw some stats in there for the males as well. Now, almost 25% of women and 14% of men have experienced severe physical violence by an intimate partner, according to this paper. And 1 in 4 women and 1 in 10 men stated that they've experienced either an injury, need for medical care, or PTSD as a consequence of their partner violence. I mean, these numbers are just astounding.
Mm-hmm.
The prevalence is highest in young adults, ages 18 to 24. So it gives us a kind of a population to kind of focus in on. And one study actually showed 21% of females and 9% of male high school students experienced physical or sexual violence by a partner in the previous year. And then the final thing I'm going to say is that they make a point of saying that groups that identify as either sexual, gender, or racial minorities tended to have a higher prevalence of this occurring as well. So good little pearls there and some scary stats.
Yeah, when I think about it, really, granted, it can happen to any individual, but these are really populations that have a hard time historically of advocating for themselves. So young people, the high schools, females, the sexual, gender, and racial minorities, all at risk, and a good reminder that we as physicians need to be the advocates.
Now, what are some of the tactics? And, this was kind of a hard paper to read. Like, it just kind of made my stomach churn a little bit. But again, I think that's maybe why a lot of us don't bring it up, is because it's just such a tough topic, and it's tough to digest. But I mean, they talk about threats, demeaning comments, humiliation, efforts to monitor or control a partner in about 1/3 of cases. I mean, these are just some of the tactics. Alcohol, medications, or illicit drugs to subdue and control another partner. I mean, these are just the facts from the paper. Victims can appear to be medically non-adherent if the violent partner interferes with their ability to seek medical care, keep appointments, or even adhere to treatment recommendations. And then the more important thing here is that there's a huge overlap between intimate partner violence and human trafficking, which has been something that's really come up in the last year or two. We've been seeing more and more about this. It's the same tactics, it's the same type of control, it's the same things that we see in both scenarios. Now, why are we talking about this other than it just being important? Well, there's actual outcomes for the victim that are important to keep in mind. There's obviously physical, emotional abuse has been shown to have a significant effect on both physical, mental health, as well as reproductive health too. Now, victims have a higher rate of asthma, arthritis, stroke, cardiovascular disease, and can even increase risk of autoimmune disorders and cancer. There are certain physical injury patterns that are more common. They talk about things like contusions, lacerations, fractures, especially in the head, neck, and face. And Specifically, I want to focus on strangulation because it's common. It can have long-term neurologic sequelae for the patient due to anoxia. And the important point is that this is one of the biggest predictors of future injury and homicide in these patients. Other things they mention are traumatic brain injuries and subsequent concussions, which are common. And then when we talk about reproductive health, female victims of partner violence have risks of unintended pregnancy, STDs, including HIV. Victims are often forced to have sex, to not use adequate measures to prevent pregnancy or sabotage reproductive measures, and to become pregnant against their wishes. I mean, again, this was just really tough to digest for me as I was reading through this.
Yeah, this is one of those big picture problems, Liam, right? Where we tend to focus on, okay, you're having an MI, but this is one of those problems where you pull back and it has, like you said, cancer, autoimmune, the children that are involved with this, the mental health. It's one of those really big society views that I think as emergency medicine physicians, we'll sometimes forget. So like you, this was a good reminder to me about looking at the forest for the tree.
Absolutely. And then, mental health, no surprise here. You'll see an increased incidence of depression, PTSD, anxiety, suicidal behaviors from the victims that are abused. Now, the paper even goes in and talks about the kids. Like you said, you kind of alluded to this. And kids that are exposed to this kind of partner violence have increased risks of not only becoming victims in the future, but also becoming violent later on in adolescence and adulthood. So that's one good reminder for us. And then the other thing that I never really thought about till I read this paper was that if you're dealing with intimate partner violence, it usually runs in parallel with other things for the kids like food insecurity, unstable housing, mental illness, and substance misuse. And so it's just, again, like you said, just a great reminder to not only just think about the victim, but also the kids that are in that environment as well. Now, I already said the scary fact is most of us have probably seen this and missed it. And I don't know really a great way other than to just be cognizant. And anytime you see an injury or a type of pattern that doesn't make sense or something that a patient keep recurrently coming back or they're not keeping up with their medical care, these are all things to kind of just keep in mind. Now, they say in this review article that both the Women's Preventative Services Task Force under the DHS and the U.S. Preventative Services Task Force recommend screening and counseling for victims with referrals for intervention. And at the end of this talk, I'm going to have two slides, one for patient information and one for providers so that they can use these resources or give them to patients, because you'll find that most of these people don't even know where to start. Now, most studies will show that interventions reduce the risk of subsequent violence, and that's why this is so important. And it's good to have everything in one location where it's easy to access. The National Center for Injury Prevention and Control under the CDC offers a huge compendium of instruments. That's one place to start. And as I said, as we get to the end of the talk, I'll give you a couple of slides that have everything for you. Now, women experiencing partner violence want healthcare providers to talk to them in a safe, private setting. And they're aware that they're going to get asked this question multiple times. But in this review, they say they just don't want to be pushed for disclosure and would like to be offered tangible medical and social resources, which we'll get to. I mean, that's the most important message I took away, is that they just want to know where to start.
And oftentimes with the universal screening that you're going to be talking about next, Salim, really, this is something where we're talking about allies. Well, I use my nurse or my MA allies, and we've pretty much implemented this universal screening. It doesn't always have to be the MD. You're definitely an important part, but remember, there are other people that your patient may be more comfortable speaking to, whether, again, that's someone who is doing the intake like an RN or an MA.
And that's exactly what we're doing in our system as well. We use the whole team. And so the nurses, when they're doing their triage, ask a list of questions and kind of go down this list to make sure that we're screening everybody who comes in. And the thing is that you're probably going to miss some people, even with universal screening. But over time, These screening questions, they lead to discussion with a clinician, right? They can at least, and provide a brief but caring intervention and offer safety and recovery strategies for these patients. And so it's not that you're going to catch it every time you ask, but it's the more times they get asked, the more they realize we're their advocates and we're there to help them. And then you already said it, universal education strategies and prevention and counseling on harm reduction is just a good, useful strategy. It's been shown to work in reproductive health and adolescent health care settings. And so they've just extrapolated that now to this topic. And we certainly are doing this in our system. Now, the pearl here is that in this paper, they say clinicians are the most effective when they offer an empathetic response that's informed by the patient's preferences and personal circumstances. And I agree with that. But I think this has to be a team effort. Right? This isn't just on the clinicians. This is also the nurses, the techs, the unit clerks, everybody in the ED. We want to be empathetic to these patients. It's really, really important. It can be frustrating in a busy environment, but we don't live in the shoes of that person. And so I think that empathetic response is something that a lot of us get jaded over time, and it's important for us to remember that. Now, one of the possible screening tools they talk about is this ED danger assessment 5-tool question set, which looks at the likelihood of severe or lethal assault. And basically, they ask 5 questions. And if you say yes to 2 or more, then you're at high risk. And it's a simple tool. It's 5 questions. And I think they're all pertinent, relevant questions. And so I think it's something simple that we can apply. And I think this is actually what our nurses are using in our triage, in our emergency department, is this tool actually specifically. It's just funny that that's what they talked about in the article. So again, big pitfall here. Greater than or equal to 2 positive answers on the Danger 5 assessment increases the risk of homicide or severe injury. And remember, I talked about this earlier. Does your partner ever try to choke you? Remember, strangulation is one of the biggest predictors and is one of the questions they ask in this tool of subsequent coming back with an injury or even homicide.
And Salim, that choking question, is that specifically focusing on what you had mentioned at the beginning, that because of the choking, these patients are because A, it's so violent that they're at risk for violence that may be deadly, but also that kind of hypoxemic event? Or why is that kind of put out there as a pitfall?
It's because it's so violent. To just imagine putting your hands around somebody's neck and what it would take to be able to do that to another human, as opposed to just like slapping somebody or punching somebody, none of which is okay, by the way. But it's a far more aggressive move. And it's a sign that there are worse things or other things that are going on as well because of how aggressive it is. It's not specifically to the hypoxia itself.
Okay.
Now, this is also kind of a no-brainer. They talk about improving healthcare systems response, and they say you're going to need to use a multi-component approach. And yeah, of course, it's a difficult thing. Resources are limited. And yeah, we're going to need a multi-component approach, like training up staff. So if this is not something that people are aware of, we're missing it. It's sliding through. Use of clinical tools like the one that we just talked about, establishment of workflow and documentation within practices. And so we do this in triage. Quality improvement. This is a great quality improvement project if somebody is looking to do something within their department. And then ultimately tangible things that they can follow up, either with social services or some other resource that's in the community that can be used. These people don't know where to start. And so having all these components is going to make it more likely that we're going to catch these people and be able to make an impact. So the next pearl is that given the high prevalence of intimate partner violence and evidence of effective interventions, routine assessment should be incorporated into many health settings and can be performed by all healthcare providers, which is what you and I alluded to. It doesn't have to be a physician. It could be done up at triage by one of our nurses. If you have advanced care practitioners or unit clerks that are doing all this, it could be anybody. If they're trained to look for it and to screen for it and it's documented, it can easily be done. But it is an important reminder to physicians as well. Now, this is the resources for patients. I'm going to just leave this slide up for a few seconds. So if somebody wants to take a screenshot of it, there are hyperlinks within the paper itself. And they give you like 6 or 7 very good resources that are tangible resources that can be given to the patients. And then the second slide is basically resources for physicians or people who work in an emergency department that are looking for something tangible to help their department. And here again, they give 6 or 7 things. Within the paper, there are also hyperlinks, but these are all listed here, and hopefully you're able to get a screenshot of that as well. Matt, that's what I got on this topic, man. Tough topic, you know?
I'm glad that the universal screening is really a hard recommendation, because if we're not looking for it, like you said, we're going to be missing it. And so something to keep on our radar and really incorporate into our role as ED healthcare providers in taking care of the bigger problems that, unfortunately are in our society.
Couldn't agree more and couldn't summarize it better. Thanks, Matt.
This is Hippo Education.